All right, welcome to this rapid fire explainer. We are going to break down the absolute most crucial, board-tested facts about one of the most notorious pathogens in medicine. We're keeping this short, concise, and straight to the point. And to make it incredibly easy for you, all the important takeaways are written right up on the screen. Let's dive right in.
Let's kick things off with a quick question. I want you to really think for a second. Across all your clinical vignettes, your rotations on the wards, and your board exams, what is the single most tested bacteria out there? You know, the one bug that manages to show up in almost every single organ system.
Yup, you guessed it, Staphylococcus aureus. Mastering this single pathogen is absolutely essential. Whether you're a med student, a resident, or a seasoned clinician, recognizing its patterns is totally non-negotiable, because honestly, it's an absolute chameleon in clinical scenarios.
To make this as efficient as possible, here is our game plan for this explainer. 1. Meet Staphylococcus aureus. 2. Classic clinical presentations. 3. Diagnosis and abnormal labs. 4. Treatment and management. And finally, 5. High-yield exam pearls.
Starting off with Section 1. Meet Staphylococcus aureus, the biochemical threat. Okay, let's rapidly fire through the organism's ID. You look under the microscope and bam, you see gram-positive cocci in clusters. It's a facultative anaerobe that's beta-hemolytic and forms these classic golden yellow colonies. But here is the absolute most tested distinguishing feature you need to know. It's coagulase positive. Also, don't forget its normal habitat. It absolutely loves to colonize the skin and the anterior nares, making a nasal carrier state incredibly common. So, what actually makes this bug such a heavy hitter? Well, it's got a massive arsenal of virulence factors. Look at protein A right there at the top. This is a brilliantly sneaky defense mechanism. It basically binds the Fc portion of IgG, essentially wearing our own antibodies backwards just to prevent opsonization and phagocytosis. Then you've got coagulates, which converts fibrinogen to fibrin, basically building a protective coat around the bacteria. It also deploys leukocidins, like the PVL toxin, to destroy neutrophils, exfoliative toxin, which literally splits desmoglin-1 in the skin, and TSST-1, a superantigen that triggers a massive systemic cytokine release.
Moving right along to Section 2, Classic Clinical Presentations, Mapping the Damage.
If you take absolutely nothing else away from this explainer for your clinical vignettes, burn this golden rule into your brain. Pus equals think Staph aureus. Literally. Whether it's a furuncle, a carbuncle, or cellulitis with purulent drainage, if you see a painful, fluctuant red swelling that drains pus, it's Staph aureus until proven otherwise.
Now, pattern recognition is everything here. You've got to link the specific trigger to the syndrome. So if a healthy patient eats potato salad at a picnic and gets sick, think food poisoning. If an IV drug user develops a brand new heart murmur, you should be thinking tricuspid valve endocarditis. Scalded skin syndrome, that's a classic for infants and young children. If a patient gets the flu, seems to be recovering, and then suddenly develops necrotizing pneumonia with cavitary lesions, that is RMSA. And for osteomyelitis, remember the specific split. It hits the long bones in children and the vertebrae in adults.
Let's zoom in on that food poisoning timeline for a second, because this perfectly illustrates a really crucial concept. At 0 hours, you ingest a pre-formed enterotoxin, say from mayonnaise or some cream pastries. Because that toxin is already formed and it's heat stable, the incubation is incredibly short. We're talking just 1 to 6 hours before you get a sudden onset of severe vomiting, nausea, and abdominal cramps. Notice there's usually no fever here. That's because it's a toxin-mediated illness, not an actively growing bacterial infection in your gut. And we can't talk about toxins without talking about toxic shock syndrome, right? TSS is a massive toxin-mediated emergency. It's caused by the TSST1 superantigen, triggering this explosive release of IL-1, IL-2, and TNF-alpha. Clinically, what you'll see is a sudden onset high fever, severe hypotension, and a diffuse sunburn-like rash. It's classically associated with tampons, nasal packing, or packed surgical wounds. And here's a huge board clue for you. Watch out for the desquamation, basically the peeling of the palms and soles, that happens about 1 to 2 weeks after the onset. All right, Section 3, Diagnosis and Abnormal Labs, the interception. You've got to have this exact diagnostic branching tree mapped out in your head. When you have gram-positive cocci, your very first step is the catalase test. S. aureus is catalase positive, which immediately separates all Staphylococcus species from Streptococcus. Next up, you run the coagulase test. S. aureus is coagulase positive, and that perfectly differentiates it from all the other coagulase-negative Staphylococci. Stepping outside the microlab, here are the key imaging and fluid tests you need to memorize. For a skin abscess, grab an ultrasound to confirm that fluid collection. Suspecting endocarditis, go straight to echocardiography. And remember, a transesophageal echo, or TEE, is way more sensitive than a transthoracic one. If you suspect osteomyelitis early on, an MRI is your best bet since X-ray changes show up super late. For septic arthritis, you've got to tap the joint. You're looking for a WBC count over 50,000, predominantly neutrophils. And if you're hunting for MRSA, you want PCR testing for the MEK-A gene, which codes for altered penicillin-binding proteins.
Which brings us to Section 4, Treatment and Management, the counterattack.
Okay, listen closely, because this is absolutely critical. If you have an abscess, your absolute first step is incision and drainage. Before you even think about prescribing antibiotics, you must drain that fluid collection. Antibiotics are generally reserved for later, like when there's a systemic illness, extensive cellulitis, or if the patient is immunocompromised. Now, when you do pull the trigger on antibiotics, you've got to split your brain right down the middle. MSSA on one side, MRSA on the other. For methicillin-susceptible Staph aureus, your go-to drugs are nafcillin, oxacillin, decloxacillin, or cephalexin. But if that MEK-A gene is present and you're dealing with MRSA, you need to escalate. That means reaching for vancomycin, linezolid, daptomycin, though a quick side note, daptomycin is not for pneumonia, or TMP-SMX and doxycycline for skin infections. There are also a few special scenarios you need to watch out for. For toxic shock syndrome, we're talking a medical emergency requiring aggressive IV fluids, source control, and a combo of vancomycin and clindamycin. Why clindamycin? Because it actually suppresses the bacterial ribosome from producing the toxin itself. Pretty cool, right? For osteomyelitis, prepare for the long haul, 4 to 6 weeks of IV antibiotics and possible surgical debridement. And for food poisoning, supportive care only. Antibiotics are strictly not indicated because remember, the bacteria isn't infecting the gut. You're just dealing with its preformed toxin. Finally, we're at Section 5, High-Yield Exam Pearls, the ultimate takeaways. Let's lock these golden rules in for good. Gram-positive clusters that are catalase and coagulase positive, that equals S. aureus. Protein A, it's the shield that binds the IgG's Fc portion to stop opsonization. If a patient gets the flu and then develops severe necrotizing pneumonia, think MRSA and the PVL toxin. An IV drug user with a new murmur has tricuspid endocarditis driven by S. aureus until proven otherwise. And scalded skin syndrome is caused by the exfoliative toxin targeting desmoglein 1, giving a positive Nikolsky sign, but because the split is superficial, it wonderfully heals without scarring.
And that wraps up our rapid-fire review. But before we go, I want to leave you with something to really chew on. As MRSA strains continue to evolve globally and collect new resistance genes, how will antibiotic resistance alter these classic clinical presentations in the near future? I mean, will the patterns we rely on today still hold true tomorrow? Keep that in mind as you study, and I will catch you in the next explainer.